Have you ever felt like your doctor wasn't taking your symptoms seriously or frustrated that there wasn't a solution for your problem? Unfortunately, you're not alone. Many patients feel dismissed and unheard in the healthcare system, which can lead to missed or incorrect diagnoses as well as prolonged pain or discomfort. Our guest today is a practicing physician and an author who will share insights on why this happens and how patients can get the care they need. We'll also discuss how patients may dismiss the healthcare system and the real consequences of doing so. Hi, I'm Dr. Mitzi Crockover, and welcome to Beyond the Paper Gown. I am so glad you're here for a truly impactful episode. Just a reminder that the information you'll hear is for educational purposes only and is not intended to be used as medical advice. And before we get started, I'd like to invite you to sign up for our newsletter at beyondthepapergown.com so you can be informed of our new podcasts and articles and other useful health and wellness information. You can also subscribe to this podcast on your favorite podcast platform. And if you enjoy this episode, please do rate us. It really does make a difference. So now that we're done with the housekeeping, let's get started. Today, it is my honor and pleasure to introduce you to Dr. Angela Marshall, who is founder of Comprehensive Women's Health Incorporated, which is a primary care practice for women. She is a board-certified internist and fellow of the American College of Physicians, and she has repeatedly been named a top doctor by the Washingtonian Magazine and a contributing health expert on CNN, Fox News, PBS NewsHour, and OWN. She is currently the chair of the board of directors for the Black Women's Health Imperative and is the newly elected president of the Montgomery County Medical Society in Maryland. Welcome, Angela. And I can call you Angela because you are a good friend, and we happen to sit on the board of the Black Women's Health Imperative together, which I am so honored to be a part of.
Yes, thank you. Thank you for having me, Mitzi. I'm so absolutely honored to be here.
I have always admired you and your work. You are an internal medicine physician, adult medicine, who focuses on women. You are now the author of what I think is going to be a real game changer in so many ways, and that is the book that you have called Dismissed. It's not only an important book, but as I read it, it's obviously a very personal book. So could you just share with us what inspired you to write that and what you hope folks will get out of it?
Yeah, well, dismissed. And when I think about kind of what motivated me to write it, it really is a culmination of a lifetime of challenging experiences in healthcare. And so I start with the fact that growing up, I grew up with a single mom, very limited resources, and I don't share this very often, but I grew up without health insurance. And, after I got my usual vaccines for school, I never went to the doctor. And so at the age of about 8, I remember I was having these horrible headaches, and my mom finally, scraped together, the money it took to go see an outpatient doctor for headaches. And, he saw me, and I don't remember much of an exam or much of an interview or, but at the end he said, "There's nothing wrong with her. She's perfectly fine." And so it wasn't until I attended medical school that I learned that I suffer from migraines.
Mm.
And that was my first encounter of being dismissed. And I think that experience really resonated with me as an 8-year-old young girl that, maybe that I wasn't as important or what have you. And, it wasn't until later that I realized that that was my first experience of feeling dismissed.
Yeah, and just for the audience, I'm sure that many people know what migraines are, but these are not your average run-of-the-mill headaches. They can be quite debilitating and
Yes.
really cause a lot of problems.
And if I can just add that the book, one of the things that inspired me to write the book, it was not just my personal experiences, but it was hearing the stories of so many of my patients. And, for years, I've heard of patients, in fact, that's one of the reasons why they've come to me as a woman physician, is that they felt dismissed by their prior physicians, or they felt like, no one listened to them. I hear that often, that they didn't feel listened to. And so this work is about, their stories as well as my own.
I think that women maybe disproportionately feel dismissed. And maybe I know that because I am a woman and have been dismissed myself or feel like I have been. But as you said, having patients come in and just, saying, no one's ever heard me, or I've been told that this was all in my head. But just to underline that, there was a study published in the Journal of General Internal Medicine that found among 800 patients, 30%, almost a third, reported feeling dismissed by their physicians. And then when we get to women, 29% of women ages 18 to 64 reported that their doctor had dismissed their concerns during that time. And that was a survey done by the Kaiser Family Foundation. And that was compared to 21% of men. So there's still a significant amount of men that feel dismissed. It's just, I think, disproportionate.
Exactly.
Let's talk a little bit about why you think that is.
Well, interestingly, I feel like when you feel like you've been dismissed in a medical situation, sometimes it's hard to understand why, right? So, me as a Black woman, one of the first things I think of is because I'm Black, you know. Um, you know, Sometimes it's our race, sometimes it's our gender, sometimes it's the doctor was having a bad day, and so we don't always know why that is. But what resonates with us is what usually resonates with us is what makes us different, right? And our brains try to explain why we didn't get what we thought we should. And so I think that's where the bias piece comes in, and that's one of the reasons why I didn't want to make this about medical racism, because as a Black person, a lot of times I think it's race related. But as a woman, I can tell you that it's not because I see women all day long and women tell me the same thing, right? And I have patients with disabilities who, they're not seen, they're not heard. I have patients who are overweight who feel that the doctors blame everything on their weight, and so it goes way beyond that. And so when I told this story, I didn't want it to just be about me and my experience, but I wanted to make sure to cover others' perspectives in this book as well, because everyone deserves a voice and everyone deserves to be treated well and everyone deserves to be seen.
I think at the very least, we feel being dismissed is an inconvenience or a frustration, but it can have real significant clinical consequences. And you actually have a number of examples of how bias, racism, sexism really impacted some of your patients. Can you draw upon one or two of those stories and tell us a little bit more about that?
Sure. There are a couple patient examples that I share. One is of a woman who was having shortness of breath. She happened to be African American, um, overweight, and suffered from anxiety. So she had mental illness, overweight, African American, and a woman. And she was having shortness of breath without chest pain, and she had seen a cardiologist, and she had risk factors. She had really severe diabetes and risk factors for heart disease. And I was very concerned about a potential cardiac cause or heart problem that was causing her shortness of breath. And so I sent her to her cardiologist. This is someone that she had in a longstanding relationship with, and he told her, "You're fine. You just need to exercise more and you need to lose weight." And so she came back to me, and I said, "Well, no, we can't exercise until we get your heart figured out." And so I sent her to another doctor. These are two male doctors, by the way. So the second doctor I sent her to was also a male. He told her she just needed to relax, and he recommended transcendental meditation for her to relax because he thought her shortness of breath was from anxiety. And that wasn't good enough for me. So I then sent her to a third cardiologist, and this time I sent her to a Black woman. And I called the doctor beforehand and said, "Hey, this patient is having shortness of breath. She has diabetes, hypertension, all these risk factors for heart disease. Can you please, take a look at her?" I said, "I think she needs a catheterization because she'd had a stress test, but those aren't always as conclusive as
Sure.
catheterization." Sure enough, she says, "Absolutely, she needs a cath." And so she took the patient to the catheterization and found that one of her arteries was over 95% blocked. So if she had exercised like that first doctor recommended, she probably wouldn't have made it. And so, that's just one of many stories that I've heard. I also think about people like Dr. Susan Moore, who
Oh,
was
yes.
her story went viral during COVID. She actually had it's uploaded a video onto social media because she wasn't getting the care that she deserved. And she also happened to be one of my high school classmates.
Mm,
And ultimately she passed away from complications of COVID. But the fact that she felt that she wasn't treated, and in her case, she says, "I contend if I were not Black, this would not be happening." And so just the thought of her having that feeling in her last days, it just, sticks with me and resonates with me. And, this is why one of the reasons why I continue to do this work. Um, I had my own situation as well, horrible experience, one of the worst days of my life, in fact, the worst day of my life, of losing my own child after being dismissed by a doctor. And it's just, when these things happen, when you're in your most vulnerable state, because in healthcare, when you go into the exam room, you know, you have to share personal information. You're often not feeling well. And to top all that off, half the time you have to take your clothes off too, So it's just one of the most vulnerable times. For patients, and when you're in such a vulnerable state, and to have people not listen to you or dismiss you, it's just very hurtful.
absolutely. Well, let me say, I think I've said this to you, but I'm so sorry for both of those losses, both of your colleague as well as your son. You are very honest in your discussion about that episode. And would you mind, because I think people are going to wonder a little bit more about those details, if you wouldn't mind sharing that?
Yeah, so and it's taken 20 years to be able to talk about it, and lots of therapy. But I had my second son in my fourth year of medical school, and he was born with some congenital abnormalities, but he was progressing well. And at 4 months of age, he had a doctor's appointment one morning, and but when he woke up, he just didn't look like himself. I mean, he looked really sick. He was breathing really fast, and I had never seen this before, but his eyes were crossing in
Mm.
just different directions. And so I immediately called the hospital, and I was thankful that he had an appointment that day. But I called the hospital and said, "Hey, we're on our way. He's not well. Something is very, very wrong. Please be ready." Right. And so got him to the hospital, and immediately I felt like the doctor didn't share the same concern that I did. I was, just really emphatic, like, "Hey, here,
Of
we're
course.
here. What's going on? Here, find out,
Mm.
here, help him."
Sure.
And
Understandably
from
so.
the right, and from the very beginning, he's just moving slowly, and finally he says, "Well, we're going to admit him to the hospital. I think his electrolytes are off. We'll get him some fluids and tank him up, and he'll be back to his self in no time." The problem was that the hospital was full, and we were waiting for a bed. And so after about maybe 15 minutes or so, I said, "Hey, aren't you going to start treating him now? Because, I don't know how much longer he can breathe at this high rate." He was breathing literally at 100 times a minute.
Mm.
And I knew from my pediatrics rotation that in children, their respiratory rate is a big indicator of distress. And, he just didn't seem phased. And he says, "Well, no, we're going to wait for a bed." Then he went away. He kept going away. He kept leaving the room. That was the other thing. And I kept having the nurse call him back. "What are you going to do? What?" And finally, he he tried to reassure me. He says, "Look, I've been doing this for over 30 years. He's going to be fine. We're going to get him fluids, and he'll be back to himself in no time." And because I was actually about to take him downstairs in the hospital to the emergency room because they were moving so slowly. That last bit of reassurance, it actually made me even second guess myself, because then I thought, well, geez, I even felt a little embarrassed. I was like, "Oh, well, am I being too hysterical here? Have I overreacted? And I second guessed myself. And then he walked out of the room one last time, and the nurse was still there. And within minutes, my son coded.
Which means his heart stopped and his breathing
His
stopped.
heart stopped. He stopped breathing. The nurse and I had to start performing CPR in the hospital until the medical team arrived. And it was just, my son didn't make it.
I'm so sorry.
And um, I really feel like he didn't make it because he was dismissed, and I was dismissed. And, and as if that weren't bad enough, um, about a month later, I had to go back and finish my last rotation of medical school, which happened to be radiology. Well, there was only one location for the radiology rotation, which happened to be in the same hospital where I had lost my son. And that was the last month I needed for graduation.
Mm.
And I can remember the first day of that rotation sitting on the bench in front of the hospital thinking, I don't have to do this. I could just quit. I really wanted to quit. But then
Sure.
I thought, how could I best honor my son? And the answer was, I can be a better doctor one that listens to their patients. And that is what inspired me to go back in there every day for a month and finish medical school.
Thank goodness that you did. And it also, I know, inspired you to write this book, which will help so many people. And that couldn't be a more important legacy. And thank you for sharing that very personal story. As you were talking, obviously I've not experienced, such an extreme situation, but I think so many people listening could see themselves in parts of those and having had that experience. And you talk about, in the book, you do look at it from a doctor's perspective as well. And it dawns on me, there's a lot of reasons: too busy, especially now with, what's been going on with the health system. There's too little staff, there's too little support. But at the end of the day, it's really about compassion and empathy and understanding. The other piece of it, as you well know, and I do too, that medical training is grueling. Most of us went in to help people, right? I think there's very few people that did it for the money. Certainly not anymore, right?
Not
But
anymore.
but I think we all come in wanting to do good and do better and all of that. But yet, as you point out in the book, and as we know, it's a long road. There's not a lot of sleep. It sometimes feels abusive. So it almost takes that compassion and empathy out to a certain extent. What is your thoughts about how medical education can address any of this?
Well, I'm glad you pointed that out, Mitzi, because you know all too well, we're programmed in medical school to, put our personal needs aside and, be be on at the beck and call of our patients and to um, just really give everything for their benefit. Oftentimes, our basic needs are not met. Even in the typical work day, having to decide, should I go to the bathroom now or wait until the next
Been there,
patient,
done that.
and so, these little basic need things, they tend to get pushed aside. And one of the things that my colleagues said to me is that we're indoctrinated. And I had never thought about it that way. Like we're indoctrinated to work, 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 work. Kind of like soldiers, I guess. We're indoctrinated to work grueling hours and to work when we're sick.
Even the word
To
indoctrinated, doctor,
Yes,
almost. Very close.
exactly. Exactly. And but I feel like we're indoctrinated to ignore our basic needs and to push, even in the face of, our own, challenges. And I think that doesn't make for the best care.
If someone who's listening here, again, resonates with this and says, okay, I think I was dismissed or not listened to, I mean, you have to accept what you're feeling and honor that. But I also worry a little bit that we go immediately to that if we hear something that we don't like. It's really hard because you do look to those physicians, to other healthcare providers, because they have the knowledge, we have the knowledge, supposedly. But at the same time, there's so much frustration about feeling like there's got to be an answer. Why am I dealing with this? And what we know in terms of women's health, which is, both of our focus, things like endometriosis, we don't have a good solution because it really hasn't been researched up until recently, and there really hasn't been any movement in it in decades, right? Even heart disease in women, we haven't had the research. How do you know if that's the problem or It may be that the again, there's that bias going on. What would be your recommendations for folks as they feel this and think about how they might want to act?
Well, for one, I think we all have to work towards promoting more research for women, for minorities, for every segment of society. We need more research, especially though for women. We need more women in research because, as you mentioned, there's so little. They'll do a study on men for a new drug, and then all of a sudden, prescribe it to women. But we all know that women are physiologically different than men. Even at the molecular, at the DNA level, we're different.
Absolutely.
And so it's not enough to just say, oh, it worked on all these men, so now we're going to prescribe it to women. So
Sure.
we as women really need to demand more women in research, in medical research, and also knowing for those who question us being so different, we have different symptoms for everything, right? For heart disease, men have one set of symptoms, women typically have different symptoms. And so sometimes if the male symptoms is the reference, and you present with quote unquote female or women's symptoms, you may be dismissed because it's not following the textbook um, script for what you should be feeling. And I just feel that dismissal oftentimes stems from not listening, not believing, or not caring, or a combination of those, which, none of those are acceptable. And so I think the most important thing we can do as women is to find providers. And I say providers because that may be a physician, it may be a nurse practitioner, or it may be a physician assistant. I'm a big believer of advanced practitioners because we need them to extend our services. But finding providers who are going to listen to you, finding people who hear you, finding people who see you is the most important, most important thing you can do right now. I do dream of a time when a patient can go into any healthcare system or any healthcare setting, and we have such decorum and professionalism and empathy across the board that they don't have to worry about not being cared for. It's just absolutely essential that we do something to fix our healthcare system. And I think it starts in medical school and in the training of medical students. And so we have to start early, just teaching the importance of empathy and compassion, and the importance of hearing our patients and not just, being able to treat people compassionately, even when their symptoms may fall outside of the textbook presentation, because I think that's where a lot of disbelief comes in. I've literally seen doctors with their eyes roll back in their head, because someone has some symptoms that they can't explain. And so we just really have to learn how to, um, you know, be more empathic and compassionate. And just because it's not in the textbook doesn't mean that what they're feeling is not real.
Absolutely. And as you were talking, I have so many personal examples of how that is. I think about my patients with fibromyalgia, for example. It's a syndrome because it didn't have, any kind of laboratory test attached to it, but yet these patients were coming in with the same symptoms. And when I was, shows you how old I am, when I was in medical school, it was called empty nest syndrome
Mm,
because women over the age of 40 were more likely to have it. Their kids had gone away. They were depressed. They were tired. Well, that's not true. I mean, it may be true, but that's not fibromyalgia. That's not what
right.
causes fibromyalgia. And I think now there's much more information about, the mechanism of it. But I had so many patients who, their doctors prior to me didn't believe it, just dismissed them, and it's a very debilitating syndrome and has significant consequences.
Absolutely.
I'm trying to think about our listeners, and they're saying, okay, I resonate with what's going on. What should I do? Should I confront my physician and say, hey, I don't feel like you're listening to me? I think that there's a real, as you talked about, a real fear that might alienate the doctor and then impact on your healthcare going forward. So, and if you don't have a choice, perhaps, maybe because your network doesn't cover changing to another doctor or you can't find a doctor in that network, what would be your recommendation to patients in terms of getting their healthcare needs met?
That's a great question. And one of the things that I recommend for patients who want to advocate for themselves in those moments is to share their feelings and not accuse, because that can be inflammatory sometimes. But if I say something like, I'm feeling very vulnerable right now and I'm in a lot of pain and I'm feeling like you're not hearing me, or I'm not feeling like you're understanding the degree of my pain. Saying it that way, I know you'll have a lot of patience to see, but I'm really struggling. I'm really suffering from this, and I don't feel like you're understanding how much I'm suffering. I think that's a good start. In counseling, they talk about using I statements, right? I feel this way. And so I think first, by sharing feelings, that's the first step. But more importantly, it's important to evaluate whether or not your doctor or your provider is a good fit for you. If it's someone who doesn't believe you or doesn't seem to care or tries to contradict you when you say you have these, well, that doesn't make sense. There's very subtle ways that people make you feel a certain way. It's important to really have a good feeling, a warm and fuzzy, or at least a level of trust with the provider that you're seeing. And so I just can't emphasize that enough. I think it's just really important to make sure that the person that you're seeing is human and they see you and they hear you.
You talked about something that I think is almost, if not a red flag, a pink flag, and that's like, well, this doesn't fit. Well, as we just talked about before, it may be because we don't have the information yet. And so I think that if someone says that, to me, that's a non-starter.
Oh, yeah. A great example of that is I have, like, sometimes when we start people on medications, right? So we usually try to explain potential side effects. And I always call them potential because I say, most people don't have any side effects on this medicine, but here are some of the potential side effects. Well, sometimes people have side effects that aren't on that list, right? So what do you do with that? So sometimes I've heard of patients going to physicians and they say, oh, I'm having, let's say, headaches since I started taking that medicine. And hear the doctor say, well, it's not because of the medicine, because headaches, that's not one of the side effects of this medicine. Well, how do we know that it's not causing headaches in that person? And so one of the things that I do is first of all, I believe them. Like, hey, you started taking this medicine and right after taking it, you started getting headaches and you weren't having headaches before, then it's probably from the medicine. So let's stop the medicine, see if the headaches go away. And if we really want to be sure, let's wait a while and restart it and see if the headaches come back. Then chances are it's from the medicine. I don't need the list of side effects from the manufacturer to convince me of that, right? But that takes believing the patient. And so I think so often, clinicians, we're so adherent to what's in the literature. And I don't get me wrong, I'm a firm supporter and believer of evidence-based medicine. We have to follow the evidence, but we also have to have common sense and we also have to be human and understand that, not everything is listed in the fine print.
And humble, right? And have some
And
degree of
humble,
humility because,
humility.
you know, going back to, women and research, 80% of the medicines that have been withdrawn were because of adverse effects in women. And so, because we didn't check, right? But that leads
Yep.
me to the next question that I know that you, and I love that you addressed this. So I remember, I'll give an example. I'd have patients who would take all these supplements that were not FDA approved, were not studied, whatever, but they wouldn't take the prescribed medications that had been, again, gone through the FDA because they didn't trust the FDA. They didn't trust the pharma companies. And there's some basis for that to a certain extent. I just gave you the data. So now fast forward, we've got COVID. We're making we're finding the science as we're going along. We're doing the research at the same time that it's, we're learning and all of that. But there didn't seem to be a real appetite for understanding, for example, that data's our information is going to change, and therefore we're going to need to change our processes to the extent, and then that became politicized, that the medical community was not to be trusted, the research community was not to be trusted, and so now then we had all of these alternative remedies that were absolutely harmful, but adopted because of a mistrust of the health system. I know that you were on the front lines. I had colleagues that were on the front lines, literally saving lives and sacrificing, their health and well-being in order to be there. So talk a little bit about that and what you think is the right approach.
Yeah, and that's a great point, Mitzi. And COVID accentuated so much. It just really amplified so many problems that were already percolating in the healthcare system. And I agree that the medical mistrust really has led to a great disengagement of the patients. And I see it a lot in the African American community in particular, feeling, when you feel like you're not listened to, not cared for, not believed, um, then, it makes you want to, go to your own devices, and natural remedies and things like that. Treat yourself. DIY health is what I call it. And that's not good for anyone, right? And so I think as a profession, the medical field as a whole, as a profession, we have to do a better job of building our patients' trust again. We have to start all over. We have got to work on trust building, and part of that involves, you know, being empathic and compassionate and bringing professionalism back to the practice of medicine. And I'm not saying that we're not professional as a group or as an industry, but the system has been so stressed over the years that we haven't been operating at our best selves. We haven't been delivering care, um, the way that it should be delivered. And, as a result, the patients have, disengaged somewhat. They've lost trust, they've lost faith in the system. And so I think we've got to it's on us, it's on physicians and healthcare workers. We've got to do a better job of rebuilding trust and repairing the system so that it is worthy of patients, coming back in a more engaged, in a more trusting way.
I so agree with you, but I have to say that I would also like to add that it would help if the outside forces wouldn't keep throwing grenades into that and
That's so
really,
true.
you know, messing
Yeah,
with people's heads.
so true. And and that's a great point because it reminds me of there's a disrespect of physicians now that we didn't see before. And not to say that we want to go back to the patriarchal uh,
God
system
complex,
where,
right? Yeah.
yeah, where doctor says do this and by golly you better do it. No,
Sure.
not that. That was the pendulum was all the way, on the other end of that. But now people feel that they can get their health care on Google and TikTok and social media, and they feel more empowered because they have more information, right? But they don't understand that the information that's on Google and social media and whatnot, even these AI, new chat GPT, we're still years away, from being able to practice medicine through an electronic machine learning algorithm, right? That's, I don't
And
think that's, yeah,
yeah, and to that point, and I think you talk about this in the book, some of that technology itself is biased. We
it
always hear
is.
about, garbage in, garbage out to a certain extent. And unfortunately, that also undermines maybe trust.
Exactly. Yeah, there's certain things like facial recognition and things that are used to treat or used to diagnose dark skin versus, there's more mistakes, if you will. But then also, even there have been AI programs used to optimize scheduling, and they tend to um, almost like penalize people who are um, repeat offenders of being late or being, missing appointments and things like that. And people who have transportation issues or people in poverty or people who have other social factors that affect their ability to get health care, they are disproportionately more likely to be eliminated from these scheduling apps. And so those issues, yes, AI can be biased, and we have to be aware of that too.
So much work to do, so little time. Um, so you end your book saying that inclusion leads to life. What do you mean by that?
Well, let me start with this. I had the honor of practicing under a physician who was and is my healthcare shero. And, I don't know if she'll ever hear this, but her name is Dr. Catherine Lucy. She was my very first physician example. She's the woman who showed me how to check a blood pressure. And there was something very different about Dr. Lucy in that she was so incredibly professional, but she was just so incredibly compassionate. She treated everyone equally. She knew enough to um, know the patients who may have struggled to get in or people who taken several buses to get into the clinic. She didn't mind that they were a little late, and it seemed as if she would give the folks who were disadvantaged a little more care and attention. She just had a way of connecting with everyone. She saw everyone. She'd look at them in their eyes and, well, how are you doing on your blood pressure medicine? And how, it was just a really incredible example to see. And I would love to get back to that style of healthcare delivery. And I have a bold goal to have that return, have professionalism return to medicine, where doctors, not only care, but we show the patients that we care, where patients feel valued and they can go in any healthcare system in the country and still feel valued. They don't have to worry about being mistreated or not heard or not believed, because we all have, certain standards of and decorum that we operate by. And so that is what I would like to see for the field of medicine. And, I'm trying to, train our new providers, and I mentor students, and even high school students we mentor, trying to encourage them to go to medical school. But, that's my vision. And I just hope that we can all work together towards that end.
Beautifully said. Dr. Angela Marshall, internist, physician leader, and now author of again, an extremely impactful book. And again, I know will have such a huge effect on both patients and providers. So thank you so much for being with us.
Thank you for having me. It's been a pleasure.
The important book we've been discussing is Dismissed, Tackling the Biases That Undermine Our Healthcare, and it's co-authored by Dr. Angela Marshall and Kathy Palikoff. You can purchase the book on Amazon and Barnes & Noble, and we'll include the links to both in the notes for this podcast. Our podcast was produced by Patrick Shambayati and me, and our associate producer is Kyla McMillian. Thank you for joining us, and be well.